Hey everyone, welcome back to my channel, and if you are new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today our guest is 𝐏𝐴𝐵 and she's going to talk about the use of pain mechanism classification system and MDT in the neurologically impaired person with pain and spasticity. 𝐏𝐴𝐵 is a physical therapist with 38 years of experience, orthopedic clinical specialist, and 𝗓𝐿𝐼𝐴 certified. 𝐏𝐴𝐵 has also co-authored the book A World of Hurt, a guide to classifying pain. I hope you enjoyed the show. PT Pro Talk podcast is only possible with the support of the forward-looking and innovative company Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi 𝐏𝐴𝐵, welcome to PT Pro Talk. How are you today?
Very good. Thank you, Mariana, for having me. I'm very excited to talk to you today.
Awesome. So our topic is 𝗔𝗯, and we're going to talk about the use of the pain mechanism classification system and MDT in the neurologically impaired person with pain spasticity. So before we jump right in, just tell us a little bit about yourself and your background.
My background. See, I'm too old to talk about that. I'm a physical therapist by trade, and I've been practicing for 38 years. And right now, my background is that I am, managing to run my own company, The World of Hurt. And I'm also working for 𝗓𝗵𝗲𝗶𝗲𝗏, formerly known as Anthem, in their back pain guide program, a direct-to-consumer persistent pain program, which is very exciting, applying some of these principles and just running my own private practice. I'm very blessed. I'm at a place where I can do a lot of different things, from teaching to research to practice, which is my most important and most favorite thing, to developing programs and creating, programs and developing teams. So this is what I am. I'm probably a jack of many trades and an expert of none. But with that, I have a lot of experience in a lot of different arenas. So, my love is treating people and canines for that matter, because my canine practice sometimes is flourishing over my people practice, but that have, pain and persistent symptoms and functional related disability. So I have given up calling myself anything in specialty other than, if you hurt, I probably can help you. And if you don't move right, I probably can help you. And so that's where I'm coming from these days. But thank you for asking.
And I know that you had a lot of experience treating neurological patients.
I have.
Right?
Yeah.
Yeah. So
I worked 35 years for the Rehabilitation Institute of Chicago, which is now known as the Shirley Ryan Ability Lab. And so having worked in that rehabilitation hospital, who was, rated #1 for over 3 decades now, we really have seen the breadth of disability, whether it was related from traumatic or progressive neurological disease or unexplainable. Saw definitely the breadth of what disability can do to the human system. So I have had a lot of experience within the neurologically impaired person.
And so let's talk about spasticity and hypertonia. So can spasticity and hypertonia be mediated by the peripheral nervous system?
Well, we're just going to say yes. And then we're going to have yes, but, because
Okay.
there are a lot of factors. And I think these are changing times. Even some of the, most well-known researchers in spasticity right now, especially those for spinal cord injury and cerebral palsy, who have spent decades in their careers researching hypertonia and spasticity have come to conclude that, peripheral mechanisms may be mediating the actual symptoms. So this isn't like new news, because it's starting to kind of make a shift in thinking. If you go to any physician or any nurse or any PT or OT or any of us, the belief is that spasticity is an upper motor neuron problem, therefore it's related to the brain. And that would be the overarching response you get. And then I say, okay, well, that's cool. Be it that it is that, then why would someone out of the blue, for no apparent reason, woke up with it, affected by moving? How could that be an upper motor neuron? How could that change? It can't. It just doesn't fit the bills. How could one limb be completely spastic, but the other three be fine? How could that be brain? It can't. And so the more confounding the characteristics and the patterns that people were displaying, the more clinically we had to ask the question, could there be another mediating source? Even when you step back and you really look currently at the medications that are being used for hypertonia and spasticity, the main ones, baclofen, Botox, right, Lyrica, Neurontin, all of these, they are peripherally acting nervous system medications. So even the pharmacological world relative to this problem has suggested that maybe people would respond more to a peripherally acting medication than a centrally acting medication. Well, the crazy about it is, okay, in true fashion, we can't plug everybody in the same hole. And this has now become quite apparent for people with a neurological diagnosis who now has hypertonia as a limiting factor to their ability to function. That we've come of the age of practice that we can't make assumptions anymore relative to it. And then when you start looking around and you're like, wow, well, why is pharmacology using peripherally acting drugs? And why are the research suggesting maybe it's not all central? Why are these clinicians seeing spasticity affected by movement related to the neck? All of a sudden, you can start to appreciate that it just was timing with this problem. The more time with the problem, the more likely you'll question the original thoughts about the problem. And that's Mackenzie's story to begin with. I mean, he grew up in the whole idea behind flex everyone, because that Williams flexion dude was flexing everybody. And then here comes him on a chance observation, put somebody in extension, and what the heck? It's no different. When we started to see this happen, and it was over 20 years ago, we were, in my mind, I was like going, wait, how could everybody who's coming to spasticity clinic, hypertonia clinic, ataxia clinic, whatever clinic we want to call it, these people with these funky movement problems, such rigidity, you cannot break it. They break the cast that we put them in. How could these people, how 85 to 90% of them are complaining of other symptoms, pain, numbness, tingling? That's too coincidental to me.
Because their condition shouldn't change, right?
Technically, it shouldn't get worse over time. Maybe it should get better over time. Brain recovers just like a muscle. So why are we seeing persistency of this? And so as we started to say, wow, well, maybe what if we evaluate the numbness and tingling and pain that's occurring simultaneously as the hypertonia ataxia? Do we see an effect? And lo and behold, we saw consistent patterns that were no different than what we've come to learn with directional preference of the spine. and centralization phenomenon with the same movements that we would do in an able-bodied. And they said the same things, like regarding onset of symptoms, timeline to problem, frequency, better and worse. They knew it already. We just didn't ask them those questions to see the pattern, to have the chance observation. So this is what's yielded for me over, the last 2 decades. And, to say, wow, unpublished in my own practice, over, I think, 1,600 cases evaluated. 45% of those cases had a directional preference that was mediating the upper extremity, lower extremity spasticity, which means they just needed the same routine we've come common to know. 45% of those people.
It's a lot.
That's a lot, and then what's even more shocking is that 25% of those people just needed us to do good old-fashioned neurodynamic tensioner exercises. They didn't need us locally stretching the wrist, the elbow. They needed us globally stretching the nerve. And by lengthening the nervous system, we lengthen the local tissues and reduce the spastic responses. So here now we're sitting 45 and 65. That's 70% of the neurological patients coming to a spasticity hypertonial consultation clinic. This means that they're the ones that we're struggling with the most, right? We're not throwing people in clinic that we're getting better. We're throwing in people in clinic that we have no clue what's happening and we don't have a direction of care. Now, what do you have? You've got 60 to 70% of those people showing up with just simple musculoskeletal related issues of directional preference exercises of the spine and neurodynamic tension exercises to the upper limb and lower limb. Well, that sent me on a rebellious crusade to make sure neurological patients understood how to rule in or rule out, whatever your preference is, this idea behind these musculoskeletal problems. Not because we're not going to treat function. We always treat function, but should they be doing a priming exercise for their function, whether that priming therapeutic exercise was at the neck or the back, or whether that priming exercise was at the nerve with neurodynamics, we should be adjusting the specificity of intensity and dosing of therapeutic exercise to improve function. And we actually should set a goal of reduction and abolishment of spasticity, because in those two situations, it can be reduced and abolished.
Okay, a lot of questions.
Wow,
coming in.
Didn't I just throw it out there, man?
Yes. Okay, so can you actually see patients abolishing the symptoms or the spasticity? Or so after you screen for derangements or other conditions, then what is left is the real neurological problem? Or sometimes it's not, and it's not, sometimes not even the problem really neurological. How is that working?
Great segue. And yes, when you actually have the effect of reduction and abolishment, now the neurological system is in a place where it can actually recover. Think about it. When you have such spasticity, and I'm using the arm because we're on a podcast and you can see my arm. When I have got that spastic response, my brain's recovering. It's a time-dependent, stimulus-dependent recovery system. But if my arm is irritated relative to a peripheral nerve problem at the neck or just an old-fashioned tight nerve, I can't get motor recovery here. I can't.
Yeah.
the dominating irritation to the peripheral nervous system is prohibiting neural recovery. So now I do exercises to my neck and my arm relaxes in complete release because I don't have the irritation to the nerve. Now I can start to see, just as we would see in our able body, distal to proximal return of function, where my hand will start having a motor response that it wasn't having. So now that motor function loss was actually dominated by the neck more than the brain. When people understand neural recovery, like when you have a spine-related problem pressing on the peripheral nerve, okay, MDT clinicians know this well. And I'm not going to go into any disc models. I'm not doing this. There's pressure on that nerve, so there's a motor component to that problem. We move the neck, it alters something within the spinal motion segment, less pressure on the nerve, they regain function distal to proximal. They have abolishment of symptoms distal to proximal, hence known as centralization. Now, when you have somebody who has a brain involvement, they have a stroke, they've had a traumatic brain injury, they have MS, they have whatever, their motor recovery is proximal to distal. So when I'm moving someone's neck and all of a sudden I see distal recovery more than proximal, I already know it's related to the neck and the peripheral nervous system. Because the brain would have it that it would go proximal to distal. I wouldn't see this until after the shoulder and elbow were far along in their recovery. The hands were ready to come. That is a golden nugget for anyone who is working in the neurological practice and struggles between, is this motor recovery central nervous system, so I should expect it proximal to distal, and I should make sure my baselines are looking accordingly, or is this really somebody who's dominated from the peripheral nervous system motor recovery? And I will see that distal to proximal, and I should set my baselines accordingly.
That's awesome.
Yeah, that's cool.
Yeah, just a good way to differentiate.
To know if the central component is still dominating or is it the peripheral component. And, you know, that really is what blew my mind, is how many were peripherally dominating in their motor recovery. And because of the irritation, they could not really get the motor recovery, even though the brain was ripe and ready for it to happen.
Yeah.
Yeah.
That's what I was curious to ask you. So after that, I'm just going to go back and say, per Mark Miller, seek and destroy the arrangements, and then we can rehab the system, the musculoskeletal disorder, whatever it's going on. Then you have the traditional rehab. But
totally.
until you haven't seek and destroy the derangements, you can't treat whatever is going on because the derangement's there. So it feels like the same idea with the neurological system. You seek, destroy the derangement, and what is left, that's what you're going to treat.
Correct. It's a nice way. And I would agree. You really need to understand that. That's why we spend a lot of time in our clinical academies at that hospital, and even on our units, not only the outpatient unit, but really the inpatient and day rehab units. Let's make sure we're understanding if these people have this component, because you can get a rapid response. The sooner we start, the better they get, the less likely they're going to have medications and interventions that could even complicate things even more. You know, by putting a baclofen pump in someone, I can't tell you how many baclofen pumps were removed in our spinal cord injury population once we really understood that all that poor person needed to do was backward bending. Now, albeit you have a spinal cord injury, whether you're dealing with a quadriplegic or paraplegic situation, clinicians have to have some creativity in how we get that person to do some backward bending.
Yeah, that was one of my questions.
Yeah.
How are you gonna move these people? Like, how are you gonna do repetitive? Are you gonna do sustained position?
I would tell you that, let's just do some generals that we have seen for the clinicians out there that want to migrate their practice this way, because there's tons of volume, let me tell you. But you have somebody, and let's talk spinal cord injury for a moment, because with spinal cord injury, depending on how long the person has been chair dependent, they can have pretty significant obstruction to extension.
Yeah, it makes sense.
Okay, we should hear that. And they will often tell you their spasticity is worse sitting in the chair and trying to transfer, and all those force flexed motions, dressing, all that. And they will tell you, if they have time laying flat, that they can feel a little better. But it takes them a long time laying flat to get to that bettering. And we all know as MDT clinicians what they're saying is, I've got huge obstruction, give me time in sustained positions to reverse the curve and mitigate the obstruction. So this is not an uncommon thing that you hear in a person with a spinal cord injury dominated by spasticity related to the spine. First, the number one thing they tell you is the spasticity was removed from the trauma. There's only a very small subgroup of people that actually have spasticity occur at the time of the injury. That is a huge factor that everyone should be asking, because in good research, that group of people did the best with baclofen pumps. And that group of people, more than likely, the trauma to the cord is the source to the spasticity. So having a baclofen pump help mitigate maybe a very good option to maintain their function. Now, that's the small group of people that actually admit that the spasticity that they had occurred at the time of the injury. Most of the time you hear, it started 8 weeks, I was in the rehab unit, doing this, starting to move. Next thing I know, I've got horrific spasticity occurring in my legs, or my legs and my arms. And that is just telling you that, okay, wait a minute, this onset of symptoms was removed from the trauma? And it seems like it's dependent on what position you're in. And when I go look at that motion and I can see that they can flex fully, these people can bend over in their chairs and touch their toes, but I can't sit them up and reverse that lordosis. And for me to get them prone, they're going to start like this in a pike. It's going to take 40 minutes for me to maybe get them propped up. That sounds like a D2 in the old school. That is a really consistent problem within the spinal cord, especially young spinal cord injury, because they're so active in their chairs now. They do so much flexion. So you have to be able to transfer them, get them prone up on elbows, prone on wedges. I had one guy lay in a hammock. His brother used to put him in a hammock every day and on his belly, and he would just lay there for 45 minutes to reduce all of the spasticity in his legs, and he would do it twice a day. Then he got to the point where he only did it once a day to maintain. This was a kid that couldn't transfer anymore. He was getting thrown out of his chair. 28 years old, been in the chair for 14 years. Once he discovered that his spasticity was just related to the fact that he hadn't backward bent his spine for 10 years, he was like, what the heck? He had his baclofen pump removed. He had almost 2 cervical syrinx surgeries thinking that was the source of the spasticity, which only made it worse.
So do you feel like most of the times when the spasticity comes after, they are more...
You'll hear that, yeah. If you're a clinician out there and I want you to ask people, when did it start? And if they go, I don't know, ask them, did it start at the time that the stroke happened, that the brain injury happened, that the spinal cord injury happened? And don't be surprised how many times you hear no.
So if they say no, do you feel like there are more chances that the spasticity is just related to a derangement most of the times?
I think most of the times there's this high chance that you should rule it out.
That's so crazy.
Yeah. So we, again, in practice, you don't get, as much. I would love to send everybody, at the time, it's like, oh, let's send them to part A, B, C, D, E, get them certified. That ain't going to happen. That'll happen if they will it to happen, but it won't happen from a standard of care. So when we were working with the neurological therapist, I'm like, ask that question. Because if that person says to you that it was removed from the time of onset, okay, and for no apparent reason this started, they cannot tag a reason for this, then the reality is that too many flexions occurred and not enough extensions, and it pissed off the nervous system, and because it's impaired, it knows spasticity, so it reacted in what it knows.
That's so interesting.
Yeah. So I think, yes, that onset question is a very important question. I think also another question is no apparent reason. And people will tell you, I mean, we've had people with neck and they woke up with it. Who wakes up with spasticity from an upper motor neuron lesion? No one.
But why do you feel like they don't respond like a normal obstruction? Because of the neurological component, they develop spasticity?
Personally, I'm going to answer it as I should. I don't know. Okay. But this is the theory that works in my mind until proven otherwise, is a neurologically impaired system. Okay. One that has an impairment. All right. We won't touch about the unexplainable impairments at this point. Let's just talk about explainable ones. There was an impairment, whether it was cerebrovascular, whether it was a traumatic brain injury, whether it was progressive neurological disease of the brain, CP. We saw in every diagnosis this happened. So we could not make it a diagnosis specific entity. Okay. But for whatever reason, when the peripheral nervous system is irritated, there's an irritation in the system. It seems like hypertonia, whether you want to call it hypertonia, spasticity, ataxia, or dystonia, because these are all manifestations of hypertonia, is ripe to happen. And so in my mind, I just think these are irritations to the peripheral nervous system. And we may not have done our due diligence to actually prime the peripheral nervous system for functional and motor recovery. So I don't know why it decides to go spastic in a certain pattern that we've agreed upon, whether it's a median nerve pattern, we've seen radial nerve pattern, we've seen all kinds of different patterns, adductor patterns, flexure, extensor synergies. We have all these names for it. But I step back and I'm like, why is that peripheral nervous system irritated?
And do you feel that the answer for that's most of the times derangements?
Too many of the times. Like I said, and that just can't, sample that I followed for a long time in the most difficult clinics, 45% of them end up being just needed a directional preference approach at the spine and completely reduced, abolished, and set up motor recovery. That's too many people. And 25% of those people weren't spine related. They needed, neurodynamic end range loading. And we needed to stop all of the local treatments and work global. So, it's really tensioning. And instead of teaching the caregivers, here's the wrist exercise, here's the elbow exercise, here's the shoulder exercise, teach that person how to do a median nerve exercise, because you'll see all the links change by just stretching the one nerve, and how much more efficient that is for a caregiver to deliver care with exercise if they're only having to do one exercise to affect 3 body parts rather than 3 different exercise programs for 3 different body parts. So, we saw, like I said, 60 to 70% of the people responding with good musculoskeletal principles. But what limited that showing up in neurological practice was neurological therapists aren't grounded in musculoskeletal repeated movement assessment, whether that repeated movement assessment's on the nerve or whether repeated movement assessment's on the neck. That is not a part of their toolbox. And because of the manifestation of these problems, when you see somebody with, forelimb spasticity, that, to your already well-adversed, I ran from them, Annie, most people will, and then there are the hearts out there that go, well, geez, I have to stay here. Now I got to figure out, what are we going to do? Right. Because they're in a bad way, so, but think about it as an irritation to the peripheral nervous system. And when we can actually lessen the irritation, we can improve the motor recovery. The motor recovery can't happen with irritation.
Yeah. And when you were talking about the extremity joints, when you were showing the dynamic stretch, if you think about it, it's the opposite of their position most of the times, right? So it would be kind of like 2 in 1. You are doing the opposite of what their joints are used to, joint-wise, and then neuro-wise, they are neuro-stretch. So,
yeah. And it's no different. Like whether if I take that, if I have a very spastic arm and, and I've cleared the neck and I can't change that. Okay, then my mind now is saying, well, maybe this global tightness that we're seeing within the peripheral nervous system is dominating all this local contraction, right? And so me taking up slack in whatever they're going to give me, and then start moving repeatedly that nerve from the top down, neck, shoulder, elbow, bottom up, wrist, bottom up, even the fingers, bottom up, as I introduce length into that neural tissue of end range, pressure on, pressure off, top down, bottom up. When I come back, what's the change in the resting tone, number 1? And what are my baseline changes in each link, number 2? And if I can come out of that repeated movement assessment of that nerve, top down, bottom up, and see, wait a minute, resting tone changes, and I change the local baselines of all those contracted joints by moving the nerve, then the conclusion is the nerve is tighter than the joints. So treat the nerve with end range motion, which is called neurodynamics. Tensioner. Yeah. And now, this tight nerve, do you think it has a timeline like derangement, or do you think it has a timeline like dysfunction?
So that was the next question I just
I'm
wrote down to ask you.
Tell me. I'm asking you. What do you think? Just from what would you think? Come on, you're smart.
Lady. I think that would be more like derangement. You would see quick responses. I don't know.
Well, thanks for answering that way, because I don't know if I sold myself as good as I thought I did. But these tightnesses, they behave like dysfunction. You're gonna, you'll get that nice response, and that's what buys everyone in, thinking it's directional preference because of the response.
Because you just said, like, we changed the baseline, so it's like, so maybe you change quickly.
Yeah, but give it an hour,
No.
it'll be back where it was.
Oh.
Yeah. The people who changed baselines relative to directional preference in the neck or the back had sustained changes. People who changed baselines relevant to stretching neural tissue had kind of what you call decrease no better, increase no worse. But you got baseline changes messing with the nervous tissue more than the local tissue, which in the neurodynamic world, which is a little different than the McKenzie mechanical diagnosis treatment world in assessment, it confirms your global tissue is dominating over your local tissue. So treat your global tissue.
So you see changes quicker than a dysfunction, just comparing, but they are not lasting because of that component, neurological component. So you're going to have to repeat that way more often and for a
twice
longer
a day.
time.
Yeah, twice a day minimally. And, 3 times a day is wonderful, but you can't get anybody to do anything many times a day. But if you can get them to do it twice a day, you're going to see statistical gains over the 6, week time frames. And if you will progress every 2 weeks, give them 14 days of what you're doing and then progress it, you're going to see. And then if you will posture that approach prior to whatever function they're working on, like if you'll lengthen the global tissue and prime that nerve and things are more relaxed and then work their function, you're going to get so much more out of the function.
And can they do by themselves the exercises?
Some can. I mean, we've got, again, I think it's creativity that kills us. Whether if it's a flaccid arm, I may need a caregiver, or I may need to prop it and have them use the other arm, have them using their neck in order to introduce a tensioner-based exercise and figuring out what link they've got the best control over. The beautiful thing about the peripheral nerve is you can access it anywhere. Heck, I've put some arms in positions and had them reach with the uninvolved arm to lengthen the neurological system. So, you lack creativity, is what pretty much, if you don't understand the principles and you lack creativity, you might run, But if you understand the principles and you'll ask specific questions and do the assessment to rule it in, and you've got a little bit of creativity with you, wow, you can really make some very profound changes,
And neck-wise, do you have to do passive? They can do active, depends on the situation.
Yeah, I would tell you the majority of people do active, and the majority of them we're treating in their wheelchairs. We don't even lay them down. My God, it's too hard to lay them down. The ones that have to lay down are typically your paraplegics, even your quadriplegics. We can lay back in their electric chairs and get big pillows under their back to get sustained extension and supine, right? Just in a reclined wheelchair, we can sit them on the edge of the bed, just lay them back on the bed and let their legs hang off the edge of the bed and get wonderful sustained extension. So the neck is very easy, and because we do it all in the chair. And think about it, most people who have, suffered a quadriplegic or a brain injury or a stroke, they have movement of their neck. The arms that they don't have it in, like they're not utilizing their spine to the best of their ability.
Yeah.
And so, it's probably easier than you realize.
Yeah. And And would you say pain, numbness, tingling are all of those symptoms clues that give you like indication that could
I
be?
do. Yeah.
Okay.
Yeah. They may be coming because of the spasticity, but one of my first questions is, do you have other symptoms in that arm, or in that leg? Other than the spasticity or the rigidity or the ataxia or the dystonia, whatever it's been labeled by somebody. So I use that label because I don't want to conflict. But I ask them, in addition to that, do you have other symptoms? And if they ask me, what are other symptoms? I say they could be pain, it could be numbness, it could be tingling, it could be weakness, and then they'll look at me and they go, all of the above. I'm like, okay, thank you for concurring that, that's good. And then I'll ask them just quite blankly, have you ever seen them behave the same? And they will say, like, immediately, yes. Like, it's an amazing thing. They know so much more about them than we do, that we are a fool not to ask them what they think, what they believe, what they've been told, and what they know, because they know a lot.
Yeah.
Yeah.
All the patients, all the answers are in the patients.
Yeah. Unfortunately, yeah.
And I was just thinking here, so about the results that you've been getting after you start applying these principles, I just imagine the difference on all the results of the pure neurological conditions treatments, right?
Well, I mean, the results is quicker motor recovery in the arm. What, one of the things that probably has brought many tears to my eyes is, people that have had a stroke, they so much want to use their hand. It's just a devastating loss. I don't think we'll ever appreciate it unless we go through the own loss of our own hand. And then to think, I can move my neck 10 times like this, and I can open my hand. That's crazy. Well, that means the neck was the reason why the hand didn't work, not the brain. Yeah. And, when you're sitting there with somebody and you've done a basic 10 reps of retraction, or even 10 reps of retraction extension, and I've made the hand worse. Which means what, guys? Go lateral. And then have the hand open. And they haven't been able to open that hand for a long time, some years, because they've just been far removed. And like Mark Miller said, hey, you can't do anything else until you reduce this problem. It prohibits you from treating anything else, and it can remain that way for decades untreated. So tears come to my eyes when people with strokes and brain injuries and even quadriplegics who realize, you got to be kidding me. So this loss of this hand wasn't completely related to my neck. Well, I said it was, but it wasn't the spinal cord injury. It was the fact that you had been doing too much head forward and not enough head backward, and it caught up with you. And so at least now when that hand goes weak, you should be looking at that hand and thanking it, because it just told you to move your neck. Yeah. And so that brings a tear to my eye, because I've seen just far too many people that have had that circumstance, and they have the same pattern. Spasticity was removed from the onset of the CNS impairment. They have decreased rotation and side bending to the side of the symptoms. They have an imbalance. They got plenty of flexion, but they don't have the extension. So they have movement loss that's very typical. And they've got a highly irritable arm that the more I stretch it, the more irritating it gets. And if I hear that from the therapist, and if I see that and I hear from them, their onset was removed, out of the blue, don't know how it happened. And I'd bet high on my paycheck that I probably have an underlying. And think about it. It shouldn't be that hard for us to grasp. As soon as this happens to me, I'm put in a bed and I've got about enormous amounts of pillows. If you've ever walked in the hospital and looked at the enormous amounts of pillows we use on people for whatever reason, plus we have them sitting up reclined. So we completely start changing the head position. Even with a stroke, because of the stroke itself, I will favor a side. So now my head's always going that way.
Mm-hmm. Yeah.
Yeah, I mean, even the CVA population had the highest preponderance of laterals. I was like, when somebody told me that, I was like, no brainer. I mean,
yeah. Yeah. And when you say that it gets worse when it moves the arm and it gets better with the neck, it's that necessarily like a relation that you see, like getting worse. If it's like a neck derangement, it gets worse when you're moving the arm versus like a dominant neurological tension component.
Yeah, you have neural tension as an able body, right? High neural tension, very irritable on stretch, with motor weakness. And you go in and perform a cervical range of motion assessment, just like we would, and notice the loss to the side of symptoms, which always raises the bar. And you go in and you perform repeated movements, and that neural tension lets up. Yeah, this is no different in somebody that has, a spastic arm with highly rigid irritability, and they don't want you to move it. And one of the things, I'll have many OTs and PTs that when we were really involved in this, they were like, we're stretching that guy. We're casting that guy to stretch out the rigidity of the spasticity. And the guy is breaking the cast. He's so irritated by the stretch. I'm like, check the neck. Because if you're telling me someone's highly irritable with static stretching through casting in the leg or in the arm, you either have a tight nerve and you shouldn't be putting it on static load like that, or you have an irritated nerve who wants to move the neck. And so just that even feature of that intervention, which is a very effective intervention for local tissue contracture, it's not good for an underlying pissed off nerve from the neck or a tight nerve in the arm.
Different from when they respond well to just the extremity component.
Again, if I've got somebody who I'm stretching that nerve and they're getting better and feels better as I do it, more than likely that's not a neck problem.
Yeah. Okay.
And think about it. My neck is going opposite the side of the problem.
Yeah.
Which if I really had an underlying neck problem,
it will get worse.
I get worse. Yeah.
Yeah. Makes sense. Very
so the differentiation of neck versus nerve can be quite compelling just through repeated movements of the nerve in the neck and using your typical baselines of motor recovery and neural tension. Now, the creativity of, working with somebody who, maybe a little slower to talk, or, you may have to coach a little bit more. That's just the creativity of dealing with somebody different. But the principles, like I said, that's why, I left you, as musculoskeletal therapist better suited to treat his problem. And, in my experience, I say yes, because they underlyingly understand centralization phenomenon, good evaluations of the neck and back. And, if they've progressed into understanding neurodynamics and the repeated movement assessment of the nerve to understand entrapment versus tightness or adherence, they are more equipped. And I try to tell neurological therapists, sometimes you don't need to be more knowledgeable about the diagnosis. after 10, 15 years of treating quadriplegics, I don't think you need to be more knowledgeable about the diagnosis, but what about understanding the musculoskeletal effects on the person with that diagnosis? That may be a growth area.
I think
Then
that's the
better
challenge.
served. Yeah. Well,
that's the challenge, how to merge those two different worlds, because as I told you, traditional orthopedic musculoskeletal physical therapists usually don't know about neuro, don't like for the most part, and it's just kind of shocking to listen to all of that, a little mind-blowing, that we can help them way more than what we think. So like, I think that's why we have to bring this information and try to share with the
you asked me too.
therapists.
You asked me best advice. I thought to myself, oh my Lord, I don't know if I can answer that question, but just a little caveat in that area is my best advice: don't pigeonhole yourself into something. It was one of the best moves I ever made as a young clinician. And again, I didn't do it knowing what I know now. When you're 22 and you're 23 and you come out cocky, I think it was a rebellious side to me because they were trying to make me a hand therapist, or they wanted me to do quadriplegic, or I don't know what they wanted me to do. And I told them, I said, I'm not any of them. I'm a therapist that treats pain and function. That's what I do. I'm not a back therapist. I'm not a knee therapist, because that's what our system was trying to do. And in my rebellious ways, I was saying, I am not any of them. And they were like, well, what are you then? And I'm like, I treat pain and I treat function. Well, now, in true fashion, what ended up on my schedule? Anybody who had pain and function. I quickly realized that everyone has pain and function. Knee people have pain and function. Traumatic brain injury people have pain and function. Everyone does. So at that moment in my career, I realized that that was a smart move for me now 38 years later, because it opened my mind to see a lot of consistencies or simple sides to complex problems. So my best advice is don't pigeonhole yourself too much, too soon, too early.
Yeah. And do you have any resource of information to recommend? I asked you that question even before we start talking, because it's like, that's a very different topic. Like, how can we inform ourselves better?
I look a lot for information that's really supporting what we're seeing in clinic, because I think clinical practice right now is way ahead of the game in regards to research in this area. Okay, I think the researchers are finally seeing that maybe we got to think differently about this problem. Okay, so I don't have anything that conclusive. Pick it up, read it, and run. You'll be an expert. Yeah. I wish I did. Now one of the things I've done selfishly, I know, we wrote a book, World of Hurt, A Guide to Classifying Pain. And that book was written after the double decades of observations we had at the Rehabilitation Institute of Chicago, using pain mechanism classification system to serve their people. Now, I tell people, you want to learn a lot about spasticity? Every time you see pain written in that book, cross it out and put spasticity. Because I would tell you, universally, we see the same thing happening with spasticity as we do with pain. And so if you want to take a different look at a problem with this fresh mindset and information, the World of Hurt, Guide to Classifying Pain will get you there, but you have to stop. Every time you see the word pain, you have to say the word spasticity, because we see these mechanisms are true for not only pain, they're true for spasticity. And the more and more we apply the principles to manage those problems, we're universally discovering that sometimes it's not about the pathoanatomical diagnosis they have. It's about the mechanism that still persists. And us understanding when to leave a pathoanatomical diagnosis to guide someone's care and use a different subgrouping model to guide care is a very important transition that clinicians need to know. So I don't have an exact resource, but I do know everything that we're talking about is relative to chapters 4 and 5 in the World of Hurt Guide to Classifying Pain, and it would be universally used for spasticity as it would be for pain.
Yeah. Well, that's all mind-blowing. All our conversation today. It's so...
Well, tell me what you're taking.
different.
Yeah, tell me what you're taking. Give me your top 2 things, like you're walking out.
I think my top 2, first of all, I would not get so scared of treating neurological patients because I would screen them first to see if there is an underlying issue that I know how to treat and I can treat. Because I'm not neuro-specialized, so I was like, well, I don't have knowledge. I don't feel like I can help these people. Sometimes we would have some of these type of patients in the clinic was like, no, don't put them on me. But I feel like now with all this knowledge, I would at least try to screen to give them a chance of not following the system that nobody's going to find out that they have an underlying disease, problem that could be easily solved or reversed to then treat the real neurological underlying condition that they have. So I feel that's number 1. And number 2, I love the how to differentiate if it's more central mediated, peripheral mediated, with some of the tips you gave that we can look for that I didn't know, and the symptoms that they have. So on the screening helps us to differentiate. So I think that was very practical. And I think it's going to help a lot of other therapists. So I think that there were 2 main things.
Yeah. Well, boy, you hit perfect. Yeah. I mean, the differentiation of central to peripheral, I think, is a huge indicator. Often OTs and PTs would bring, especially the CVA population, and I'm going to say this because they have a high prevalence of these problems. If the leg doesn't have spasticity, that's just isolated to the arm. Now, if the leg and the arm on that side are highly spastic, still doesn't make me think that it's not a back and a neck problem. But I'm willingly, if they don't follow certain guidelines and principles, reverting back to its possible upper motor neuron origin. But when I see person with the CVA come in and they got rip-roaring leg spasticity, but both arms are fine. They got
it's like
arms
right away
tied
that
up. But
light
I'm
flash.
like, oh no, yeah. This can't be. It just by the nature, it says, please look at me.
Yeah.
You fell off the wagon already.
Yeah.
Yeah.
Absolutely.
So that to me is a huge one. And if you have other symptoms, I think you need to feel much more empowered that you probably have a lot to offer with that problem that appears so scary because it's so hard to define and we still are lacking definition. We still are lacking definition. There's still disagreement within how to define hypertonia.
I feel like we are empowering more therapists, so I think that's great. Our goal is accomplished.
Good.
There was just one last question that I think you kind of answered, but if you have any other advice of personal qualities and abilities that are important to become successful, do you have any other insights?
The fact that I love that we're talking about, people that are just beginning their careers. I think this is the wisdom I could have sought, right, when I started my career. One of the things I do want us to really realize in order to be successful. And I'm just saying this, like, I'm in 38 years of practice. There's only been 2 weeks where I haven't seen patients. So I've held a lot of positions, but clinician has never left, to the point where there's only been 2 weeks in 38 years where you actually didn't formally see somebody. Okay, so, when people will ask, why, how can you still do it? Aren't you burnt out? Blah, 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 all this stuff. And it's because of this characteristic that I believe we all need to have, called love. You got to love people. You really do. Because hurting people hurt people. And people who are going in, you're dealing with people literally every half hour to every 20 minutes to every 40 minutes that are going through the worst times of their life. Your entire career is dealing with people who are going through the worst times of their life. And as much as we're so skillful and knowledgeable and all of these things, a lot of times they really need us to be able to love. They need us to figure out when to tough love, when to rescue love, when to validate love, when to encourage love, when to actually be an educator in love. But they need us to be that way. And so, I don't know, as fruity as it may sound, you got to be able to love people because you are dealing with them at their worst times of their life. You have to be able to treat the whole person. That means you have to be able to tap into their spirit a little bit, know a little bit about them spiritually, because people are hurting spiritually, especially more than ever. You have to understand where their soul is, their mind, their will, and their emotions, because a lot of unexplainable is relative to how much their soul is hurting. And yes, you have to be an expert with the body, and you have to be able to be prescriptive with your moves. So you have to be equipped to understand people's spirit, soul, and body. So to me, that's the characteristics that keep you in the game. It's not the amount of continuing ed courses I went to and or certifications I hold and or degrees. My professional accolades will never be greater than the clinical accolades of watching people succeed in their own lives relative to the information we were able to organize for them.
Yeah, very profound.
Yeah. Well, yeah. I'm a profound person. You don't go through this many years in life to not realize where'd you make a lot of mistakes. I would love for somebody to say, hey, let's do a podcast on all the screw ups that you had, because those were, times where you actually realize you need to make a move. And some of it is I really didn't understand people's spirit and soul. I really didn't. I was all about the moves, but I wasn't about the words. And I didn't know when to do the foods. I didn't know, how to really affect people's immune system through lifestyle habits and make those transitions. And, I think as a clinician, the more you can open your mind up, physical therapy is an incredible career. There's not too many professions like ours that you can pretty much become anybody. You could be an entrepreneur, you could be a manager, you could be the greatest clinician, you could be a researcher, you could be whatever you want. There's not many professions that yield that many choices. Yeah, it's a wonderful career. But the helping people part of it is built on love and understanding their spirit, their soul, and their body.
Very complex. A lot of different skills that you develop over the years to become a better therapist.
Well, I love reading about human behavior and solution-based care. People are not looking for evidence. They're looking for solutions. And solutions are not within the evidence. They're within tried and true practice. And having evidence-based medicine, but solution and practice-based medicine is extremely important, because patterns are there, to be applied and used and simplified. And human behavior is really what we're dealing with. Like, just to be quite frank, yeah.
Yeah.
I mean, how many times have you told somebody to do their exercise and they don't do their exercise?
Oh, yes.
Yeah,
Very
you have
often.
those people? Good. I'm glad. I do too.
Yeah. Well, Annie, before we finish our conversation, do you have anything else you want to add? Any thoughts?
What kind of thoughts could I add?
We had many thoughts. It was
I know we had. I just
many.
and my only final comments will be the biggest heartfelt thank you. The opportunity to talk about these passions, and these patterns and these observations is, opportunity of a lifetime. So I really appreciate you reaching out and giving us a stage on sharing this with your listeners. And, if you have questions or you want to discuss somebody, World of Hurt 2 at gmail.com is a way to get a hold of me. And I love talking about, how we mold these principles into practice. So that would be my final thank you very much.
Awesome.
For this
I
opportunity.
appreciate.
Yeah.
Yes. It was great. It was mind-blowing. This conversation was mind-blowing. So I appreciate you taking the time to share with us. And I'm sure that was very practical, and a lot of therapists are going to get a lot of this conversation. So I think that's the goal. Just bring information, and you have all this experience and all of these wonderful insights. So I appreciate you taking the time. So,
Well, you're welcome.